I'm Peggy Peck, MedPage Today. It's the final day of the American Stroke Association's International Stroke Conference in San Antonio, and today is the day devoted to late-breaking clinical trials. Of all the trials that fall into that category, none has been more anticipated than the CREST trial, which is a NIN-sponsored trial that looks at carotid artery stenting versus endarterectomy. And to speak with me today about those results is Dr. Ralph Sacco from the University of Miami, a stroke neurologist who is also president-elect of the American Heart Association. So, Doctor, long-awaited trial. What do we know from this?
So you're right, this is really late-breaking information. The CREST trial has been long-awaited study on carotid endarterectomy, the gold standard operation that we've used to prevent stroke in people with symptomatic and some people with asymptomatic carotid artery stenosis, versus angioplasty and stenting using a very similar stent and neuroprotective device. This NIH-funded study was done in the United States in multiple centers, and it really took about 2,500 patients, randomized them to these two procedures to see which was superior over the other. The study was designed to look at 30-day outcome of stroke, heart attack, MI, and death, as well as long-term risk of ipsilateral stroke to the carotid artery that had its intervention. It was done among centers that are really expert. They really had to have a run-in for this trial, both to prove that they could do endarterectomy well, as well as do angioplasty and stenting with a high quality. And the results of the study show no difference between these two interventions. Overall, there was no real difference in the long-term outcome of this outcome for endarterectomy versus angioplasty and stenting. At 30 days, it looks like the stroke risk was actually a little lower in endarterectomy versus angioplasty and stenting, and the MI risk was actually a little higher with endarterectomy versus angioplasty and stenting. The long-term risks in both groups, though, were quite low, and this is an important piece of information because it tells us about the long-term durability of both endarterectomy as well as angioplasty and stenting for preventing a stroke in people with symptomatic carotid disease, as well as a group with asymptomatic carotid disease.
So, from your perspective, does this level the playing field in terms of selection of procedure for these patients?
Well, I think this study tells us a little bit more information about actually the safety and long-term efficacy of angioplasty and stenting. We've known for many years now, and we've had Class 1 Grade A recommendations regarding carotid endarterectomy for symptomatic carotid stenosis. We haven't been sure about angioplasty and stenting. There have been some trials that have suggested some benefits and some trials that have not suggested as many benefits. I think this study, in showing the similarity between these two interventions, it gives us a little bit more positive information about angioplasty and stenting. However, there's going to be more information we're going to need. The trial is just going to be published. There are going to be subgroups that we're going to have to look at. Does the asymptomatic group do as well as the symptomatic group? And what about age? There's actually an interesting finding on age. Those under age 69 actually did a little bit better with angioplasty and stenting than endarterectomy, while those over age 70 did a little bit better with endarterectomy. So there's still things we're going to have to figure out with this study, but I think it really helps provide a lot more information regarding angioplasty and stenting against our gold standard carotid endarterectomy.
Well, we really can't even discuss this trial without mentioning that these data were reported here today just about 15 hours after data from a European study of a somewhat similar design were reported in the Lancet. And in that case, in the ISCC trial, there was a clear edge given to endarterectomy over stenting. And in fact, there was an increase in MI, which were fatal, and stroke, and overall death in the stenting arm. So, how to put that, it seems to me like we're swinging from one side to the other. Let's try to give some clinical implications here.
Well, it's always difficult to compare across different trials. However, the International Carotid Stenting trial, as you say, did show less of an effect, in fact, a significant better outcome at 120 days. And it's important to emphasize that the international trial was really an interim safety analysis and really focusing on the early period, the period that we do believe is the greatest risk, but it focused on 120 days. The international trial was only on symptomatic patients. The international trial was not done in any U.S. centers, and the international trial used many different kinds of devices, not all with neuroprotection. So there was a little bit more heterogeneity, we'd say, in the international stenting arm. However, it is still a very important piece of information. The rates in the international trial in both groups, both the endarterectomy and the angioplasty and stenting group, were higher. But in that trial, it also showed that actually endarterectomy was superior to angioplasty and stenting in the 120-day outcomes. But the rates were higher in both groups compared to the rates seen on the CREST trial.
Mm-hmm. I've talked to some other researchers that really are involved in trials of this type, and they've mentioned that in the European trial, they raised some questions about the training of the operators, the interventionalists. There were 64 aborted procedures because they could not access the carotid, and I'm told that that's an unusually high rate.
Yeah. Well, the CREST trial, will tell you, did everything possible to try to reduce the issue of any perioperative morbidity and mortality. We selected surgeons that were really high quality, and they also put the operators for the angioplasty and stenting through a training program, and they really had to show their results before they got into the trial, and there was almost what we call run-in phase. So that was critical. I can't really comment on the quality of the operators in the international trial, but like any new procedure, you do need high quality. Our current American Heart Association, American Stroke Association guidelines call for, when you do angioplasty and stenting, you have to do it in the symptomatic cases with a less than 6% risk. Less than 6% risk. That's the same level we've used for endarterectomy. We want the perioperative 30-day risk to be less than 6%. The numbers in the international trial may have been a little higher than that.
Mm-hmm. I see. Well, Dr. Sacco, I want to thank you very much. This was interesting news today, long awaited. We'll have to see how it plays out in clinical practice. And I look forward to seeing you in November at the American Heart Association Scientific Sessions. From San Antonio at the American Stroke Association InFocus, I'm Peggy Peck, MedPage Today.